And just like that, we're back and we're recording a few lectures here, and it's been a marathon so far. That's okay. We got this. Let's talk about management of these respiratory disorders. First and foremost, let's make sure we give them lots of oxygen, okay? Any patient showing a sign of hypoxia, let's give them oxygen. I'd much rather take it off of them once I get their SAT readings than to not give it to them when they absolutely need it, okay? There's been a lot of emphasis on not over-oxygenating a patient. I don't disagree with that. With that being said, if I walk in and I see signs of hypoxia, let's give them some oxygen until proven otherwise, okay? A couple minutes of oxygen till we determine that, not going to hurt them that bad, okay? Again, now we're talking about, days and weeks of doing that. Yeah, probably a bad idea, all right? So your O2 saturation, this says 96. Oh, yuck. No, let's change that, okay? Because guess what? The number is the magic number that we're always going to try to remember. 94 to 99, okay? Now, I know that he says that there's mild hypoxia at 94 and 95%. It's okay. It really is okay. 94 to 99 is where the sweet spot is, okay? That's where we want to be, all right? Again, you can worsen the patient's outcome. Remember that little 2-3 GPD thing that we were talking about when the oxygen hemoglobin dissociation curve? Yeah, that would happen because of too much oxygen. It actually shifts it over to the left, which it can cause more problems. So the oxygen is kind of more freely released. And so you'd say, well, that's a good thing. Well, the problem is if it releases early, it doesn't get to the things like the muscles that it needs to get to. Okay? So again, when he was talking about that, that's what he was talking about on that particular video, okay? So excess oxygen can form toxic chemicals, which are known as free radicals, and again, they can lead to certain cancer situations. So provide just enough oxygen to treat the hypoxia without over-oxygenating them. By the way, when we over-oxygenate, the other thing that we usually do when we do that is cause problems with the brain, especially clamping down on the brain's circulatory system. That's one of the things that the brain does is when there's too much oxygen, it kind of starts to clamp down, which of course can be a problem. And again, so let's not do that, especially if they are a neonate, by the way. Yeah, you can blind them. Let's not do that. Upper oxygen airway obstructions. Again, the number one is the tongue because it relaxes and it falls back in the back of the throat. I would say in the EMS world, especially the old people world that we live in, dentures is probably number two, okay? Then, look at your surroundings and your environment. The kid's sitting there with a half-eaten hot dog. Hello, newsflash. The kid is sitting there and a bunch of coins are laying out, or buttons, or pennies. All of these things can do that, okay? It can be a result of facial or neck trauma. Any type of burn. Again, we talked a lot about this in airway. Secure that airway, secure the airway, secure airway. In severe signs, again, they might have a silent cough, cyanosis. They might not even be able to talk or breathe itself, okay? If you've got an airway that's troublesome, you doubtful that you're going to get an ET tube through there. You really need to be thinking surgical airway at that point, okay? And by the way, if you think it's swollen, it's probably going to be swollen where you're going to do the cutting. So if it's going to be what I would call an airway nightmare. Again, unresponsive patients, remember the dentures get loose, the tongue falls back. Again, simple head tilt chin lifts, guys, do wonders. An OPA does wonders. Simply when you put the OPA in and you see the loose dentures, pull them out. Okay? Speech indicates an obstruction is incomplete. So if they're still talking to you, that means they still got some airway, okay? If they are unresponsive, they've been eating, again, you got to suspect that the food is lodged in the trachea. Again, it's McGill forceps time, or using your BLS maneuvers in which to get them to come out. If it's burn, please assume that they're going to have laryngeal edema. It is not the time to wait. It is time to do it. It is time to get that airway in before you can't get it in. Watch out for hives, again, especially with an anaphylactic situation. You can get that throat swelling. Again, be mindful of it, all right? Intercoastal muscle retractions, if they're using their neck to ventilate that against a partially closed airway. So that could be a clue that they've got some sort of obstruction in that general area. You see that a lot in trauma, by the way. You'll start seeing that. If they're using those neck muscles, even though they're not responding, that usually means that they're trying to force things open in that general and of course, we all know that it's got very hard tissue there, so it's doubtful that it's actually going to do any good. Okay? Again, NPA, OPAs are wonderful with the tongue issues, especially in OPA. Drop that thing in there. LMA, King tubes work great as well. All right? So if you got a conscious adult and determine that they've got a complete obstruction or a poor obstruction with that if you got an upper airway obstruction, again, severe obstruction with a poor air exchange, you need to provide abdominal thrust and be ready in rapid sequence. You want to do this old school. You want to get it out, force it out. Okay. A conscious adult, usually the head tilt, chin lift. You're going to use CPR, and if it still persists, and they can't, usually when you've got a foreign body in there, it's going to relax, and most of the time you can get it out by doing the chest compressions. It actually kind of forces it out. At that point, you can get it out pretty easy. But if not, you're going to have to go in with again, you're going to have to visualize the airway, take McGill forceps, and get those things out. Okay. And again, I can tell you that I've had some interesting cases. Beefsteak, collard greens are two of my favorites. I got to be honest with you. All right. So again, if you've had an upper airway obstruction, start your IV. Again, intermuscular epinephrine can help to reduce the airway swellings. And again, Benadryl it can also reduce this, and it reduces for an allergic reaction problem that you might have. Okay. Remember, this is only for an allergic reaction problem that I would consider any of those. But if you've got a lot of swelling in the airway and you know you've got swelling, epinephrine can be used in order to do that. Let me just make sure. Yep. Okay. We're going to talk about ARDS real quick. This is a life-threatening condition which affects the gas exchange. There's a fluid that accumulates within the interstitial spaces. If you've seen up in the ICUs, the X-rays that are full of fluid, this is a acute respiratory distress. So what happens is you get leaking into those areas, and it decreases the fluid removal from the lungs. Okay, and what really happens is essentially they're drowned into death. If you really stop and think about it, this is kind of how the very late stage of a CHFer actually ends up dying, is through acute respiratory distress syndrome. Okay, and the mortality is very high, especially it results in kidney failure, liver failure, as well as respiratory failure. By the way, your COVID patients are filling up with not only these fluids, but it actually kind of turns hard. And again, it affects it in the same way. So you need to be aware of those situations. So look for the clinical symptoms that were, again, usually you got great SATs, even though you got horrible SATs, even though you got great ventilations, okay? And usually these folks decline in respiratory status, and it's usually kind of a slow one. They start getting short of breath, confusion, agitation, with the cardiogenic pulmonary edema, okay? Long and short, it's not their heart that's causing it, okay? We kind of treat it the same way about getting the fluid off of it when we know that it's ARDS, okay? Infections can sometimes cause this situation with again, when the fluid starts leaking into those alveolar sacs and causes a lot of trouble. Tachycardia, tachypnea, two big signs of this, okay? You're going to get crackles, and they're usually going to be a finer crackle. They're not like the gushing, thick rails that you normally hear with a lung infection, but they can be thicker because of the infection process that causes it usually. And you have to manage their underlying medical condition. If it is an infection, we got to treat the infection. Again, how do we treat the infection in the pre-hospital setting? We get them somewhere where they can treat it. We can start treating CHF. We can start treating that with diuretics and nitroglycerin. We can get CPAP in order to force the fluid out. So ARDS, CPAP usually works pretty decent with ARDS, by the way. It kind of depends on how thick the mucus is down there, or how thick the the problem is. It's kind of why I'm having you guys do the SAA on COPD versus CHF. If you've got thick secretions down there, the CPAP can actually help you to ease the work of breathing, but it might not displace everything like you want it to displace, but it will help open up the alveoli up top. The problem with the inelastic lung in COPD is that you could pop said lung. Congestive heart failure, on the other hand, again, if you've got a lot of thoracic pressure, you're going to be putting more pressure on the heart, but it helps force the fluid out. Just like any tool that we have in our toolbox, these are tools we got to really look at to see if it's our time to use it or not. Okay, so ARDS usually use some sort of treated. We get the fluid away. We remove any type of toxins. We descend to a lower altitude. Remember HAPE, that's when you've got a high altitude pulmonary edema. Again, they're not used to the shift in the pressure. So these guys, again, those are the most important therapies. But you got to figure out what's going on with the patient. Getting a good history, okay? Absolutely essential to figuring out this patient's in an acute respiratory distress system. And then usually just supplement the essentials. Make sure that the air is going in and out. Make sure they have a good oxygen saturation. All right. Get your IV established. Cardiac monitoring. Suction of any lung secretions. Positive pressure ventilation works pretty good. CPAP can avoid the need for endotracheal intubation. And that's one of the biggest things I want to stress to you. You don't have to intubate these folks. CPAP, BiPAP work really good on them. Okay. So let them, this is one of the things that we can use to augment them without going full plastic on them, all right? And we don't really want to do that. Make sure that we get them in there to the pulse oximetry, and make sure you take them somewhere with an ICU that can actually put in your advanced monitoring techniques. Yeah, we're going to need to put that Swan-Ganz in and mechanical ventilation support. That's probably going to be needed for the first couple days, all right? Just so we make sure that their hemodynamics are staying normal, okay? Remember, your Swan only gives us how much preload is coming back to the heart, which can be essential for judging that case, but we can also find out how much blood is going to the pulmonary arteries so that we can monitor those pressures, okay? So very important to understand it, and for that reason, we're going to watch this video. Yay, stand by. 3, 2, 1, find my marker here. I am clicking here. Oh, playback trouble. Oops, sorry about that again.
This induced ARDS, bacterial toxins arriving at the lungs in blood, cause macrophages and neutrophils to adhere to capillary, endothelial, and alveolar cell surfaces. Lung damage is a result of a systemic process initiated by burn tissue, infection, or inflammation, rather than a direct lung injury, although inhalation damage may be causal too. The macrophages release a variety of substances that damage both the alveolar walls and the capillary endothelial walls. In response, the endothelial neutrophils release lysosomal enzymes that cause more damage, resulting in leaky membranes. The damaged capillary and alveolar walls become leaky, allowing plasma, proteins, and red blood cells to enter the interstitial space. As the interstitial fluid accumulates, the pressure rises and forces fluid into the alveoli through the spaces in the damaged walls. The pressure in the capillaries that normally drives fluid out of them into the interstitial space is usually counterbalanced by the osmotic pressure of the plasma proteins. Once these proteins are in the interstitial space, the pressure balance is disrupted with further net loss of plasma from the capillaries into the interstitial space and then into the alveoli. Protein-rich fluid accumulates in the alveoli and damages the surfactant-producing alveolar cells. As more and more surfactant is lost, the alveoli stiffen and collapse, so normal expansion and contraction stop. Decreased alveolar compliance, atelectasis, and fluid-filled alveoli interfere with the exchange of oxygen and carbon dioxide across the alveolar and capillary membranes. Blood oxygen levels fall. Carbon dioxide levels also fall, as the increased compensatory respiratory rate blows off more carbon dioxide. Fibrin from plasma and debris from dying cells combine to form stiff hyaline membranes which line the former alveolus, further reducing alveolar compliance and gas exchange. Blood carbon dioxide starts to rise, since it will not diffuse across the hyaline membranes, and oxygen levels decrease as no oxygen can enter the stiffened alveolus. This leads to respiratory failure and often death.
And if you really stop and think about this, gang, this is how the COVID is actually working on this. So, again, when I talk about recruiting alveoli, by pressurizing this, I can stretch these out and start to remove this layer. And when we do that, then the lung tissue starts to actually function and work again. Now, it's not going to happen when it gets to be this severe. It's going to take some time for that to drain. But the ones that are barely in that first earlier stage, where we can force that protein-filled fluid out, that's actually where the CPAP comes in very useful and very handy. All right, so we're going to talk about this on the next video, and I will see you then.